continue to welcome you. Recognized teams from Mbale region or the Eastern region, Mbale region Referral Hospital. I've seen Yumbe. I've seen those within Runyoro here, but are coming from the other districts of Kagadi. You're most welcome. Feel like this, please enter. Sit wherever you feel comfortable. And if you're a graduate, you're going to sit on the other side, on my left. We are soon starting our first program, so I hope everyone has the program or the end of the day, the copies attached to your invitation cards. We are going to have the first presenter soon. We will be introduced to you. As you remember, the theme of the day, kidney health for all, caring for people, protecting the planet, and we are at Hoima Resorts. We are going to have, this is how everything's supposed to go. Supposed to have opening remarks. We shall have these topics: diabetes, kidney disease, new strategies, shall have anemia in CKD, new opportunities, conservative kidney management, farmer-sponsored talk, a session of questions and answers. We shall have acute kidney injury in children with malaria, then dialysis options in children, peritoneal dialysis, Uganda's experience. We'll have acute kidney injury in critically ill patients, and then thereafter there will be also another session of questions and answers. Then we're supposed to have, after that session, the second session of question, Q&A, we'll have tea break. Then we'll have another session after that break of quite a number of issues. We'll address CVD in chronic kidney disease patients, updates on glomerular nephritis, nutrition and the kidney. For those who do not have these copies of the program, I'm just reading it out, and each of those programs have someone presiding over it, and they're all here and ready. So as we wait for them, as we wait for a few things to be put in place and prepare, I'll be inviting someone who's supposed to give us opening remarks to be ready. I'll be requesting Dr. Louis Nyende to prepare for the opening remarks so that we can have an official start of the day of the program. So it's always good to dedicate ourselves before the Lord before we start our day. We shall have an opening prayer, and I will request a volunteer by show of hand to raise their hand and offer us an opening prayer. If not, okay, thank you.
Someone says the word of prayer. Father in heaven, we thank you for this day. Thank you for enabling everyone to come for this function. We ask of you that you will guide us, you will lead us, and through all these sessions, you will be made manifest to the glory and honor of your name. For in Jesus' name we pray.
Amen. Thank you so much. I request the co-MC to introduce the first presenter. As we also recognize, I hope the people following online, I hope they've already been connected. Thank you if you're there. Thank you for being with us.
Good morning, everyone. It's with great pleasure that I would like to invite Dr. Nyende, our chairperson for this year's World Kidney Day celebrations, to give his opening remarks. We welcome Dr. Nyende. We are going to give him time. He will introduce himself and then give us his opening remarks. Thank you.
Thank you.
Please give him a round of applause.
I was supposed to speak without a speech, but I had to prepare a speech. Let me open it. You're welcome to Hoima, our chief guest, and all members, the president, past president of Uganda Kidney Foundation, past and immediate, distinguished guests, colleagues, partners, ladies and gentlemen. It is my great honor and pleasure to welcome you to the World Kidney Day 2026 Scientific Conference here in Hoima City. Allow me to first recognize the tremendous work of the organizing committee, whose dedication, long hours, and teamwork have made this conference possible. Please join me in appreciating their effort and commitment to advancing kidney care in our country. We are deeply honored by your presence in Hoima, and your support reminds us that improving kidney health requires collaboration between clinicians, policymakers, administrators, and the community. I also wish to recognize the leadership of the Uganda Kidney Foundation, including our past presidents and the immediate president, whose vision and guidance continue to shape the growth of kidney care services in Uganda. To all the delegates, I say welcome to Hoima City. We hope you had a good journey, and we hope as you entered Hoima, you will at least saw some of the oil that has made this region famous. If not, don't worry. By the end of this conference, we hope you will have discovered something even more valuable than oil, the strength of kidney care community. Hoima is a city on the move, and as many of you know, this region is preparing to host the African Cup of Nations 2027 tournament. And we are proud to say that we now have an international airport as well. And these developments remind us that growth and progress are possible when there is vision, learning, and partnership. The same principles that guide our work in kidney care. This gathering reflects the strength and unity of the kidney care community, and we're encouraged by the growing participation of clinicians, nurses, scientists, trainees, and especially young researchers. Seeing the young generation taking interest in nephrology gives us confidence that the future of kidney care in our country remains bright and full of promise. On behalf of the organizing committee, I sincerely thank all delegates, partners, sponsors, and members of the kidney fraternity for your commitment and support. This year we joined the global community in observing the World Kidney Day theme, caring for the people and protecting the planet. This theme reminds us that kidney care is not only about treating disease, but about caring for the whole person. Our patients depend on us not only for dialysis, medicines, and transplant, but also for compassion, dignity, and hope. At the same time, modern kidney care uses significant resources. We must be mindful of our responsibility to practice medicine in a way that is sustainable and environmentally responsible. Protecting the planet means thinking about how we deliver dialysis, how we use water and energy, how we manage medical waste, how we ensure that life-saving treatment remains available for future generations. Caring for people also means focusing on prevention. Preventing kidney disease through control of hypertension, diabetes, infections, and unhealthy lifestyles is one of the most powerful ways to protect both our patients and our planet. Every case of kidney disease we prevent reduces the suffering. It reduces the cost, reduces the burden on already limited health services. Allow me to briefly share about our experience here in Hoima. Dialysis services were started in August last year, 2025, and as we speak we have 5 dialysis machines. Today we are running dialysis 6 days a week, Monday to Saturday, serving an average of 3 patients per day. And these numbers may look small, but behind each session is a life being supported, a family being given hope, and a system that is growing stronger. We have also managed patients for acute kidney injury and chronic kidney disease, and we look forward to publishing our experience soon, including the testimonies of patients whose lives we've touched by these services. These stories remind us that why these meetings are very important. The scientific conference brings together experts and practitioners to discuss key areas: hypertension, chronic kidney disease, dialysis, glomerular diseases. And over this period, we shall be inspired by new ideas, strengthen collaborations, and renew our commitment to improving kidney health. Let us use this meeting not only to learn from each other, but to encourage one another to build partnerships and to move forward with a shared vision for a better kidney care. And we hope that the social moments during this conference will strengthen our friendships and remind us that the progress in medicine is built on teamwork, trust, and dedication. My name is Louis Nyende. I'm a physician. I'm also the head of internal medicine at Hoima Regional Referral Hospital, and also the head of clinical services there by the grace of God, and also the nephrologist in the unit, and I'm also the chair of the World Kidney Day. I wish you all a productive, inspiring, and enjoyable World Kidney Day 2026. God bless.
Thank you, Dr. Nyende. Please let's give him another round of applause. At this juncture, allow me welcome our chairpersons for the first session. The first chairperson we have is Dr. Muhindo Rose. She's a senior lecturer in the Faculty of Medicine at Ibarra University of Science and Technology, specializing in renal medicine. She also serves as a physician at Ibarra Regional Referral Hospital, the university teaching hospital. She obtained her Bachelor's of Medicine and Bachelor's of Surgery from Ibarra University of Science and Technology in 2003, and later earned a Master's of Medicine in Internal Medicine from the same institution. She further advanced her nephrology training as a clinical fellow at McMaster University in Hamilton, Canada. With those few remarks, kindly allow me welcome Dr. Muhindo Rose to take her seat. Our next chair is Mr. Atubo William. Atubo William works at Hoima Regional Referral Hospital as a dialysis nurse. Kindly give him a round of applause. Next, our chairs will introduce our presenters. So Dr. Rose is going to introduce our first presenter to take the floor and present to us. Thank you.
Thank you very much, Olive. Good morning, everyone. Yes, you all look amazing from up here. Thank you for taking the time to come to this wonderful city. Yes, so as you've heard, my name is Rose, and I'm proud to chair this session with Atubo William. We'll also say something small, but very quickly, before I introduce our presenter, let me ask William to also just say hello to us.
Hello everyone, good morning. Good morning. My name is Atubo William. I'm a dialysis nurse at Hoima Regional Referral Hospital. You're almost welcome to Hoima for this great celebration. Please feel comfortable, and the oil is enough. We will travel back safely.
Thank you, William. Yes, so it's with great pleasure that I would like to introduce the first speaker of the day, my president, Dr. Ogavu Joseph. So Dr. Ogavu he holds an MBCHB, M.Med in internal medicine. He's done EXACOP. He has a fellowship in nephrology. He has 101 titles. Dr. Ogavu is a teacher, he's a physician, and he's also a kidney health expert. And his greatest pleasure is in looking after patients with kidney disease. And he takes pride in doing advocacy for patients that have kidney disease. And he has also asked me to remind us, or inform us, that he also, outside of the kidneys, he makes juice that is kidney protective. So I would like to, I hope we'll get a sample before we leave. Yes, so Dr. Ogavu. Dr. Ogavu is also the president of the Uganda Kidney Foundation. So Dr. Ogavu, he's going to take us through diabetic kidney disease, the new treatment strategies. Over to you, Dr. Ogavu.
Good morning. I take great pleasure in being the first presenter in the first World Kidney Day celebration in the holy city of Hoima. Thank you very much. I must tell you, I used to come here maybe a decade ago, and the way that's really transformed this place, and with the promise of us carrying some oil in our pockets, I can't be happy. Yes, I hope we shall be as happy as those two fellows there. I have a disclosure to make. There is a promissory note from Michael Labs if I present very well for this presentation. Yes, so that's the disclosure that I have. We shall do a few case summaries that I hope will intrigue us. CKD in the world, the heat map that we know very well, and mortality, a few definitions, prevalence, and what drives TKD, as well as how the diabetes management has evolved and where we are today. And then we shall look at our cases again and see what our thoughts could be. Right. So not so long ago, I had a 55-year-old man who's a trader, resides in the city. Sorry, Hoima, I read this summary from Kampala, and I thought there was only one city, but this one was in Kampala. Known to have hypertension and diabetes for 10 years. His drugs then were metformin, glucosamine, and nifedipine. You could tell that he got this prescription eons ago. He had no complaints according to him, but he came to check in hospital, and those were his BPs. His HbA1c was 9.5. He had a macroalbuminuria, as you can see, and his GFR was 62. He also had an ECG that revealed LVH. The second is of a 61-year-old female, type 2 diabetes, hypertension, 10 years, being self-medicating for blood pressure, on fedpin, has come under cardio and nephrocare, occasionally runs out of breath during sleep. He was obese. This was a male, my apologies. Grade 2 edema, dyspnea at rest, those were the pressures, and you can see that his EF was low, 38, hyperlipidemic. Also had severely raised, moderately raised urine albumin. What else would be of value in his assessment, and what pharmacological interventions would you really consider? Now we must talk about CKD and how it's rising. We all know this figure, and we know that by about 2040 or 2050, we shall be the 5th leading cause of death. I wish this was something to celebrate, but just prepares us for what is coming for us. And you can see that despite having little attention, diabetes is a driver of most of what we are seeing. Everyone has to acquaint themselves with this heat map, because essentially in our clinic, we are fighting the red and seeing how we can get our patients into the green. And you know that albumin and the great microalbuminuria or macroalbuminuria for that matter, as well as the GFR, are indicators of chances of one dying. We must also really understand that the risk of dying in patients that have CKD is very high, and our own Prof. Kazi have demonstrated that these people have up to 4+-fold increased risk of dying from anything. It doesn't matter. And so we must protect our patients from cardiovascular disease, because it is what kills most of them. Those of you that have looked after these patients for a very long time, you can actually testify that these patients die quite a lot from, especially cardiovascular. We're talking about stroke, myocardial infarction, among others. I really struggled. This took me time to squeeze into one page. I hope my friend ChatGPT did some good work. So the key features of diabetic kidney disease are really albuminuria and normally you should not take any protein, any albumin in the urine. And so anything above 3 milligrams per deciliter is not a good thing. So you want your patients below. Anyway, in the definition, more than 3 milligrams per milligrams per millimole or 30 milligrams per gram is high risk. Okay, and the progressive decline in the GFR, we shall see that normally maybe somewhere from 40 or so years above, you could drop 1.9, 2.9, maximum 3 mils per minute per year, and anything faster than that is not a good thing. Patients that are diabetic, type 1, usually after 10 years, but in type 2, it will be present even at the time of diagnosis. And commonly, an association with retinopathy, many times a diagnosis for type 1. In type 2, it may be different, but you do not need retinopathy for you to have diabetic kidney disease. The definitive diagnosis would be a biopsy, which rarely do. You do it, however, if there are red flags like you have overt proteinuria, subnephrotic or nephrotic, you have an active sediment in the urine, you have a more than rapid drop of your GFR, and if your sugar and pressure are otherwise controlled. And many times when you have investigated a drop that is faster than we think, we find patients with multiple myeloma among many other things. So don't always conclude that it is diabetes. That's why you must do imaging, things like tumors, cancer of the cervix, see a prostate, among other things. So don't take it for granted that everyone that has kidney dysfunction in diabetes is because of diabetic kidney disease. So diabetic kidney disease is a common complication, and it may vary from between 30 and 50% of individuals with diabetes. However, type 2 is the commonest cause worldwide, and we know that in Uganda about 33.7% of type 2 diabetes patients have a degree of kidney dysfunction that we may not conclusively say is diabetic kidney disease, but certainly exists, and that is what has been done by people we know. So if you have a drop that's more than 5 mils per minute per year, you really have to worry about that one. However, the normal one should be, like I said, 1.9, sometimes up to 3.3. Average being 3. People with high risk of decline, if the pressure is not well controlled, the sugar is not well controlled, if they have severe proteinuria, despite them having an initially normal GFR, and those that smoke. So you can already see the things that we need to tackle. Smoking, manage your pressure very well, manage your sugar very well, and your urine protein will be a good marker of how you should intervene. I always like to make these slides, and it's crowded, that's what it is. And if you think this is complex, it was so simple those days, because you just need to worry about your weight and sugar. Then you dish metformin or glucosamine. Life was very easy. If things are bad, you put insulin, you're a very good doctor. You do that today, people will scream. Okay? And 2022 became more complex. We have to think about atherosclerotic cardiovascular disease risk. We have to think about heart failure. We have to think about CKD. We must think about risks of hypoglycemia or not. And we have to think about the weight, certainly, and things like amputation, and then you choose which drug to use. Come 2025, it's still more complex. And like I say, I don't regret posting this, because the message is treating your patient is not simple. Okay? Don't just give everyone the same drug. You must think about your patient. You must think about whether they have a diabetic foot. You must think about whether they have a risk of hypoglycemia. You must think about their weight. You must think about whether they have heart failure. Okay? You must think about their risk. What is their lipid level? Have they had a stroke before? And all these things have to be considered. And so, today, We have some say 4, but we clearly know that up to 5 pillars. And don't be surprised if you wake up tomorrow and you added the 6th or 7th. And all this is because we have come to realize that their management is beyond just showing. And so I'll just take a brief moment, a slide or two, on each of these pillars. SDLT tools are fairly new, but you may find that the first drug was actually invented more than 30 years ago. It just took long to trickle down to us. We know that it's associated with weight loss, improved cardiovascular outcome, reduced cancer risk, improved renal outcomes, reduced stroke risk, lower blood pressure, as well as improved glucose control. In fact, they are probably less efficient for sugar control, as many of us have experienced, but the patients benefit a lot from others. And then, despite them being so many, it helps to know what your patient actually has. So if they have a high risk of atherosclerotic cardiovascular disease, or they already have one, then your choice will be that of empagliflozin over the others. Risk of fractures, again, empagliflozin. Established heart failure, it's been found that empagliflozin has better outcomes than canagliflozin or even DAPA. So you want to choose. It's not the same shoe fits everyone. And then come the GLP-1 receptor antagonist. So we know that diabetes and high sugar is a state of high inflammation, and there are so many ways in which it's done. It does that: oxidative stress, increased fibrosis, atherosclerosis, and somehow these magical drugs are able to tackle from insulin resistance to weight loss to improving your blood pressures and glucose levels, as well as reducing inflammation, and they have become a pillar in the management of our patients. Before it was very expensive, but we probably all know a drug or two that's available just by the stroke of a pen with your prescription. And they have been shown to reduce the risk of progression of chronic kidney disease and drop in GFR of more than 40%. In fact, these trials were stopped early because there was clear evidence. And so that's one more thing that we have in our center for managing these patients. And then we all know, sorry, I tried to get a bigger one, and it was quite difficult for me, but I can take you through. Again, same, you have inflammation, fibrosis, as well as systemic vasoconstriction and sodium retention arising from the activation of RAS, all complicated by hyperglycemia, high salt intake, as well as oxidative stress that we know that accompanies elevated blood sugars and the glycogen degradation products, among others. And we know that inhibition of the RAS actually has benefits in this beyond just the mechanistic prevention of vasoconstriction. Perhaps this is a drug we should take. These are drugs, SCIs and ARBs. We should not take so long on them because for more than 40 years we have known them to be beneficial, and no doubt their addition on any treatment, as long as it is safe, certainly helps. Then comes in the SGLT2 inhibitors. These two, whether alone or in addition to other drugs, have been shown to be very beneficial. And then Peritoneal is a new drug, which is a non-steroidal mineralocorticoid receptor antagonist. It's fairly new, less risk of hyperkalemia, diverse benefits from the heart to the kidney, even to the lungs. So it's a drug that has also been shown to significantly reduce proteinuria, as well as reduce the drop in GFR. I think this should have come after the previous slide. But again, it's clear to us that the addition of SCIs or angiotensin II receptor blockers is clearly associated with a reduction in the drop of GFR, a reduction in proteinuria, not mentioning their benefits with the heart. Right, and so SGLT2s, sorry for the mix-up here, but there's a recommendation for type 2 diabetes patients with CKD as long as their GFR is above 20 mils per minute to get onto a statin. And if they have moderate increase or macroalbuminuria, then you need to put them on an SGLT2 inhibitor. These are KDIGO guidelines. Heart failure, irrespective of the level of albuminuria, and GFR 20 to 45, but with reduced albumin, when not so much, you still need to put them on statins. When not to put or when to hold them, if they are undergoing surgery, they are having prolonged fast, or they're in critical conditions, you could stop them for a while. Some concerns about euglycemic DKA, among others. Also, if patients are not tolerating them, or when you initiate kidney replacement therapy. But remember that your patients don't only have kidneys, they have the heart, among many other things. So if the cardiologist needs the drug on, don't initiate wild war. You want to win. Okay, the patient benefits from the drug, they still have a heart. So unless you're having a strong reason not to keep them on, please keep them on. And then the fifth pillar, the statins. First of all, not everything is manageable by drugs, so if your patient can go on a plant-based diet, the better, avoiding bread and processed meats and refined carbohydrates. And the point here is that their conversion into fats, which you want to fight, is very easy. Statins as the first line to maximize absolute risk reduction, especially in those that have elevated LDL, and they have actually been shown to be of a better benefit in patients that have higher GFR. So initiate them early unless you have a contraindication. And those above 50 and GFR grade 3A to 5, treat with a statin or the combination of a statin and ezetimibe. And those with grade 1 up to grade 2, again, we use a statin. So they have a very good place, especially so in patients that have diabetes, like we have seen. And all in all, the reduction in cardiovascular risk certainly reduces non-fatal myocardial infarction and coronary deaths reduced. So unless you have a contraindication, your patient benefits from having a statin. And so we go back here. Like I said, 20 years ago, when I was in medical school, again, this patient would have been managed very well. Metformin, yes, beclamide, you know your medicine, Vet-Pin, and that's it. But as we shall see later today, I think there are ways to manage both the heart and the kidney. So you think about all these things. So the pressure here is not to target. And what will happen with this pressure, the chances of them knocking their kidneys out are high. So targeted blood pressure, this patient being diabetic and already having macroalbuminuria, you want this pressure below 130/80 millimeters of mercury. Your HbA1c is still a young person, and unless they have risk of hypoglycemia, you want this below 7 as much as possible. And today you have a wide array of drugs that you can actually choose from. The beclamide, probably not a great choice now, because even in the sub-Saharan areas, drugs like glimepiride are associated with a less risk of hypoglycemia, but also better HbA1c reduction. Metformin is perhaps a good drug. The GFR is still good and maximize. Don't just tax the patient with 500 milligrams OD or BD. You've seen these prescriptions. So metformin is a very good drug before your GFR drops. Drop it below 45, maximum 30, and your patient will be very weak. You have to take metformin and get sicker. You take it off, life comes back. Nifedipine, not a great drug. You have drugs that can manage your pressure better with good renal outcomes. So an angiotensin 2, angiotensin 2 receptor blocker or an SCI for this matter comes in handy, and is SGLT2 inhibitor. So you probably will overhaul this treatment except for the maximization of metformin. And your patient having LVH already, you don't want more remodeling to happen, you probably have a role for a non-steroidal mineralocorticoid receptor antagonist in finerenone, or if it's not available, you could still use the lower options as long as you monitor your patients for hyperkalemia. Your patient being in the OECD, I want to assure you we are able to afford some of these medicines, including follow-up. I really argue that we should not keep patients away from good medicine for fear of not being able to monitor. Yeah, because you're better off with a better heart than living in fear of maybe I'll get hyperkalemia. Time 20K, monitor, and you have your answers. And this patient here is obese, they have some edema, dyspnea at rest, the BP is known to target. You probably want a drug that reduces the weight, in addition to talking to them very well regarding diet, physical activity, and what have you. This particular patient actually we gave semaglutide, and they lost their weight tremendously. I must tell you, when this guy walked in, the lines are usually long. About 4 of the patients that came after him were saying, how is that man alive? Because he was breathing and everyone in the waiting area could tell he had trouble walking. The next time he came with the wife, I don't know, I won't tell you how much was added to my wallet in terms of Mazike. They were happy because the man was improving, and sometimes you know that they even improve in the other area, which you have already understood. So beyond glycemia, you must think about the weight of your patient. Think about injection fraction. Think about the lipids. So this patient walked away with a statin, walked away with an SGLT2. I comfortably added a non-steroidal mineralocorticoid receptor antagonist. Get him some diuretic there. I chose an ARB for his pressure, and certainly got semaglutide with good benefits. So the take home here, diabetes care and CKD is very much individualized. Don't treat your patients the same way. They are very different. So not one size fits all. Cardiovascular risk, heart failure, renal, limb loss, weight, glycemia are all to be considered when you're minding these patients. This care keeps evolving. I told people about 15 years ago, and when I look at those slides, I laugh at myself. But that time I did so well, because that's what I was supposed to do. But if I lapse and sleep for about 1 year, things could be very different. Cost and choice have literally ceased to be a big issue. Anywhere now you can manage your patient very well, and thanks to the pharma that have made this possible. If you see this sign somewhere, it's
Co-chair to welcome and introduce the next presenter. Co-chair to welcome and introduce the next presenter.
Thank you so much. Ladies and gentlemen, at this moment, allow me to invite another presenter, and that is none other than Dr. Senator Francis Ronnie. Dr. Senator? Okay. Sorry about that. I'm told it's going to be Dr. Chigundu Daniel, who is already in the house. Dr. Chigundu Daniel is a practicing internist and consultant nephrologist at Chirudu National Referral Hospital. He trained in the Division of Nephrology at the University of British Columbia, under the auspices of the International Society of Nephrology, and subsequently passed the European Specialty Examination in Nephrology. Dr. Daniel Chigundu is passionate about the systemic delivery of accessible quality care for patients with kidney failure in low-resource settings. He established the pilot satellite dialysis outreach service to shorten travel distances for patients at Chirut National Referral Hospital. He has led the opening up of Lira Hospital Dialysis Unit, Mbale Hospital Dialysis Unit, Hoima Hospital Dialysis Unit, and Kawempe National Referral Hospital Dialysis Unit. At this point, Dr. Daniel Chigundu, you're most welcome.
Good morning. Thank you very much for the kind introduction. It's my pleasure to be here in Hoima once again. Privileged. I've come to Hoima when it's already reached, not like Dr. Gabo, who remembers the days that were hard. Dr. Gabo has done some of the work I needed to do, so I've built some sections that he's covered. So I am going to talk about conservative kidney management. And we've already gone through some parts of the presentation, but what I'd like you to know about chronic kidney disease, the way we see it in Uganda, is that most of our patients come late. This heat map shows everybody is assigned a place in this map, and there's a green and yellow and red. Most of the people are sent to us in hospitals when they're in the red, and we know this because of work that Dr. Kadesula did with a student about 10 years ago that shows that people come to us in stage 5 kidney disease. And when we compare the outcomes of those who are able to start dialysis and those who don't, they're not very different. And that makes us ask ourselves, why is dialysis often unsuccessful for us? And we think that there are many contributors. First of all, in truth, dialysis is not feasible in many of the patients that are sent to us. And that may be because of medical contraindications. So as we think about, as we preach the indications, we need to bring out that there are actually many contraindications. There are also economic factors and social factors, including things as simple as distance. The second thing is that our dialysis programs are overloaded, so we need to select our workload better so that we can deliver better outcomes. We need to improve our quality of dialysis, and we also need to increase access to kidney transplantation. To drive all these, to deal with each of these contributors, we need ongoing research to improve, to inform our actions. So, we need to carefully evaluate the candidates that we take on for kidney replacement therapy to make sure that it's meaningful. And again, I'll say this, we need to recognize the absolute and relative contraindications for kidney replacement therapy. And for those who don't qualify for dialysis, it shouldn't simply be a death sentence. We should prioritize high quality conservative kidney management for the non-dialysis group to maximize the achievable quality of life. And this means we need to take care of the patients and their families. We need to have discussions to plan ahead. We need to manage their symptoms. And when the end of life approaches, we should recognize it and deal with it calmly, and not make panic dialysis starts. So conservative kidney management can happen in environments where there's access to kidney replacement therapies. And that's the colored box. But on the other half of the diagram, you can see that there's a gray box, which means in some parts of the world, you don't have access to kidney replacement therapies, and you're going to have conservative management because that's the only choice. For those who have access to transplants or dialysis, circumstances can change. For example, a gentleman is on dialysis and then he gets a posterior circulation bleed, and you've got to decide whether it's meaningful to continue dialysis in this person. Similarly, for some people, their transplant fails and it may not be feasible to restart dialysis at this point. But for the most part, we're dealing with huge populations that can't have dialysis because it's not feasible. And so conservative kidney care management is CKD care without dialysis. The goals are to maintain quality of life for as long as possible. And we do this by preserving kidney function, and managing complications, managing symptoms. We do advanced care planning, and we also have to think about end-of-life care. To preserve kidney function, there are things that we avoid: nephrotoxic medications of many kinds, avoid herbal medications, make sure your patient doesn't get hypotensive from very aggressive blood pressure management, make sure the patient doesn't get dehydrated, and also make sure your patient doesn't get malnourished, so avoid overzealous protein restriction. What should we do instead? We should make sure there's good blood pressure control, and we should use ACE inhibitors and ARBs for as long as possible. And when you run into hyperkalemia, if you can manage it and keep moving. If you run into insurmountable hyperkalemia, then you can finally stop it. Other things that are very important are SGLT2 inhibitors that Dr. Gom has spoken about, low protein diets, and the management of metabolic acidosis using sodium bicarbonate, but also using dietary approaches. So, for blood pressure control, we still advocate for combination therapy with multiple drug classes. We use thiazide-like diuretics that have been shown to continue to work even below a GFR of 30. I'll put this line on ACE inhibitors and ARBs again, because our approach, the approach to them is changing globally, which is not just a mechanical stop to ACE or ARB therapy because of certain GFR categories, but to use them for as long as possible unless you run into hyperkalemia. That's insurmountable. So to manage fluid, we do salt restriction, but we also use diuretics, diuretics of various kinds that are available in our market. We use low protein diets, especially we advocate for plant-based diets because they deliver a lower acid load as well. And if you want to do very low protein diets, then you have to watch out for malnutrition, and you will need a keto analog to avoid protein energy malnutrition. And we have a number of these in our market and represented among our midst. Please speak to the representatives. We need a fairly big number of alpha keto analog tablets, 1 tablet for every 5 kilograms. And we divide this into 2 to 3 times a day. So we're done with the preventing progression. Now, when we deal with managing complications, we still run into some of the same things. We still control metabolic acidosis. We have to deal with hyperkalemia. We have to deal with fluids. We have to deal with uremic symptoms and anemia. This we've spoken about briefly. Limit animal protein. Discontinue drugs that may be linked to metabolic acidosis. We know metformin is the most notorious one, but certain drugs that are ubiquitous in our care, including NRTIs, may need to be rethought in terms of their doses. Fruits and vegetables come in here, so they bear potential harm from hyperkalemia, but we also know, and the current thinking is that the fruit is a complex substance, and its effect on things like potassium depends on some of the other things that may be in the fruit. That same fruit has glucose, which may help with certain potassium shifts, so it's not a universal evil. It's also helping you to avoid metabolic acidosis, so we maintain a permissive attitude to them. In terms of managing chronic hyperkalemia, well, there are medications, but there are also simply strategies that we use. You've got to have good glycemic control, because that helps you with shifting your potassium inwards into the cells. You may need to withhold RAS inhibition, but as I've said, our attitude to them, RAS inhibitors, is much more generous than 5 or 10 years ago. Make sure you avoid constipation, because the GIT increases, ramps up how much potassium it releases, and you need to take advantage of that. You need to limit processed foods, things like ketchup. You need to limit foods that are known to be very high in potassium. We need to, I've already spoken about processed meats. So salt restriction, we've spoken about these already in some of the previous slides. Managing anemia is supposed to be broad and thorough. So we should identify nutritional causes and correct them. And if for patients whose HB is below 9.5, then we've got erythropoiesis stimulating agents, but we also have the new HIF stabilizers that have been in our market for the last 1 or 2 years. 2 years, I think. Okay, so in terms of managing symptoms, we have pain, but we also have non-pain symptoms. We need to modify the analgesic ladder, because the higher parts of our analgesic ladder are founded on morphine, but there's fear of morphine. So we end up having to dose it in very low amounts or use alternatives. For step 3, we could use fentanyl. For step 2, we could use low doses of tramadol. The non-pain symptoms are what takes up a big part of our work. Nausea and vomiting, we need to use antiemetics, we need to use them for a long time. So we need to structure drugs that can, in a way that can be given for a long time. I tend to favor things that are given once a day and things that can be given durably for a while. Pruritus, we need to remind the patient to keep their skin oiled. Antihistamines are useful, but they have limits. We also need to manage phosphate. Phosphate management contributes to the treatment of pruritus. And also manage the uremic symptoms. In terms of anorexia, we need to manage nausea. We may need to use antidepressants. I favor mirtazapine in this section. Epigastric pain and uremic gastritis. Epigastric pain and uremic gastritis, it can be treated with acid suppression in the tummy. And we've covered the others. So, finally, we need to recognize that this is a person, and even though they have a limited lifespan, it will be useful for them to plan the remainder of it. We need to discuss the possibility of life-threatening events and decide what we shall do about it. Has the patient made a will? Are their affairs in order? What should we do if they get a cardiac arrest? Should we resuscitate them or not? Should we put them in an ICU or not? Who will preserve the patient's decisions when they are not able to make decisions anymore? Are the relatives empowered? And who will be the key principal decision maker? Because if we don't have this in place, we'll find that we may make decisions that reverse a lot of the good work that we'll have done ahead of time. And when we are doing end-of-life care, it shouldn't be brutal. The patient and their caregivers should be comforted. We should notify the patient and the family that the end of life is close. But we should avoid numbers, exact numbers. Because when we are wrong, then we'll be remembered for that number more than the other things that we'll have done. We need to be clear about the prognosis and set the goals of care. For patients who are comfortable enough to discuss where they want to die, you can speak about it. Clarify the resuscitation status, delineate the limits of what treatment can be done and cannot be done. Stop all unnecessary investigations, and we need to stop all non-palliative medications. Negotiate this with the family, because sometimes people feel that you have stopped the medicine, therefore you have ended the patient immediately. But we need to have these difficult conversations. So, in summary, conservative kidney management is not simply the absence of dialysis in patients with kidney failure. There should be deliberate actions and a holistic approach to promote the well-being and dignity of patients with advanced CKD who can't benefit from dialysis or other treatment modalities. Thank you very much for your audience.
Ladies and gentlemen, thank you so much, Dr. Daniel. May we give him a better round of applause? And allow me also to invite my co-chair, who is going to call in another presenter. Thank you.
Thank you very much, Dr. Chigundu. Yeah, so for those of you who look after patients with kidney disease in low-resource settings, you will realize that his talk is very important. For most of our patients, by the time they come to us, it's probably at the end of the road. The treatment options are not very affordable for many of them. Sometimes I wonder, God forbid, if I was a kidney patient, whether I would listen to what my doctor would say. But let's keep our questions for the Q&A session. So it's with great pleasure that I'd like to introduce the next presenter, who is a pediatric nephrologist, and she works in the Department of Pediatrics and Child Health at Mulago National Referral Hospital, Makerere University as well. She's the head of the Pediatric Nephrology Service. She's one of the few, or one of the two, or one of the 2.5 pediatric nephrologists that we have. She has 2 years training where she did her subspecialty training in pediatric nephrology, where she attained this at the University of Cape Town in South Africa. Before that, she had an NMed in Pediatrics and Child Health from Makerere. She's a clinical researcher and yes, so she's very passionate about children and their kidneys, and one of her main areas is really to promote early detection of kidney disease in this very vulnerable population, and she puts a lot of emphasis in the management of AKI. So she'll be talking to us about this particular topic, but before she comes, please allow me to call my sister Bira to recognize a few people in our presence.
Thank you so much, Dr. Hoima, and all people who are here. I'm so glad to stand for you to recognize some of the people we invited for this function, and I would like to take this honor to invite our director, the host, Hoima Regional Referral Hospital, Senior Executive Consultant is here with us, to recognize some of the members, some of the invited guests who are already here, and those whom we also expect to come. feel at home. Dr. Bwaga Ibrahim, you're most welcome, sir.
Our distinguished guests, the delegates, the members from the Ministry of Health, top leadership, represented here. I recognize the presence of the Minister of Health who is represented, and I'm informed they will join us. Commissioner, Clinical Services, Director General, represented here. The partners in health, we have quite a number here, and colleagues in health with whom we serve the population of Uganda. I recognize your presence today, ladies and gentlemen. My name is Bwaga Ibrahim. I'm the acting senior executive consultant for Hoima Regional Referral Hospital. I've been given the honor to recognize some officials who are with us here, and I'll just make a round. We have among us, because Hoima Regional Referral Hospital serves a catchment of 9 administrative districts. So, starting from Chibale, Kagadi, Kakomino, Chikube, we come to Hoima district and the city itself. So, here we are in Hoima city, but the district surrounds us. And then to the west, we move to Chilean Bulisa. And to the north, we go to Masindi and Chidando. Our catchment is of about 4.5 million people. And I'm very humbled to say that we have seen growth in this region globally when it comes to health. So I want to recognize the presence of the DHOs present. If you are present and DHO within this region, please stand up for recognition. Okay, I saw some, I think 3, but maybe they haven't joined. We have the office of the Resident City Commissioner. You're welcome, sir. So, the Mayor, Hoima City, represented, hasn't joined probably, but they will be with us. The DPC and RPC, you know, we can't serve people in health without their support. You're welcome, sir. So we have a UBTS team. UBTS, yes, you're welcome. We have other facilities, but among our stakeholders, we have teaching institutions. We have Hoima School of Nursing and the Kampala International University, Makerere School of Public Health, and the College of Health Sciences. We've worked closely with them, especially in areas of research. We've partnered with them, and the other partners I may have skipped, it's not intentional, but we welcome you to this occasion. You're welcome. So with those remarks, I just want to say a few remarks about our region. The Hoima region is blessed, but the blessing comes with a challenge also. We have the 9 districts. What we have in plenty is land. And when it comes to health service delivery, for a long time we had stalled, to be frank. But in the recent past, through the different engagements and the lobbying strategies, we have managed to secure progress in a few areas, especially in the area of infrastructure. I'm very happy to inform this audience that the region now have a blood bank. Have a regional blood bank, and as of last financial year, we took strides and we overtook some regions when it comes to maternal health services. We are no longer at the bottom of the league when it comes to, we hate talking about mortality, but that shows that there is some improvement in the quality of care, and that facility has aided us greatly. We have also secured an oxygen plant, a new plant that can support the entire region. Yes, we still have a few challenges here and there, but we don't have to move long distances to access oxygen services. And today we come to celebrate the World Kidney Day. But we wouldn't be speaking about that if we didn't have an ICU and where the dialysis services are hosted. So for the last 2 years, we've had an ICU complex at Hoima Regional Referral Hospital. We didn't have that facility for a long time, and what used to happen, and with this I actually want to thank Dr. Nani, who is for the Eagle's Eye, because when we are approached, and especially during the COVID time, our priority was for an ICU, but we had not really seen far to know what exactly do we need in this ICU. So when the ICU was implemented, like the infrastructure itself, we noticed, and for me, I'm an obstetrician by training, I'm a consultant in obstetrics and gynecology. What we used to see were patients with eclampsia and anemia, acute kidney injury, and the Hoima Regional Referral Hospital is 4 hours away from Kampala, whether you like it or not. And please, you don't have to drive fast, and I'm cautioning you, because ours have corners, deadly corners. So the patients would actually hesitate to move to Kampala. So we made referrals to Chirudu especially, but many would actually say no. And we have, unfortunately, figures of such patients who succumb. So their plight was for us to bring this service closer to them in this region. This region has 9 districts. Why shouldn't we have an essential service like dialysis? And many with chronic kidney disease. I liked the last presentation. You know, you tell us these things and we understand that. Please enable us to implement what you have talked about. I'm glad to inform this House that as we speak, we offer dialysis services at Hoima Regional Referral Hospital. It is one of the strides and improvements in care that we've had at Hoima Regional Referral Hospital. That's almost what we talk about in the regional referral. But we have many other services that we now do neurotrauma surgeries at Hoima. So the ICU comes to save very many conditions. We have made way for the Heart Institute regional. We have made way for a regional isolation center. We look forward to having specialized services in the region, super specialized services. So when we saw this need, and our internal medicine specialist also got an opportunity to further in nephrology, in McMaster. As an institution, we allowed them to go without hesitation. And maybe Dr. Njema can calculate how many nephrologists we have in the country? 16. You are among the 16. And how many regions we have in the country? Region. Okay. But I'm very confident that most nephrologists are in Kampala. Am I wrong or not? Most nephrologists, they're in Kampala. So for us as Hoima, Bunyoro region, some of you will hear the word Albertine. We are Albertine, the oil region. We boast the nephrologist. And we are not going to release him. I will not sign a release letter. Yes, we are making progress towards that. And with the addition of wage and everything, we are likely to bring on board more. We have other colleagues who have shown interest in other subspecialties. We have one who is warming up for pulmonology. Why won't we? We have one who is warming up for pediatric issues, and we have one warming for neurosurgery. So with all this, I think this region is blessed, and we have hope that in the near future, we shall probably be a center of excellence, which we are in some aspects. So with those very many words, really, our region is blessed, but also with challenges that we acknowledge. Among the challenges, some of our districts are still incapacitated. I have to say this. When it comes to human resource and health, looking at all these building blocks of health, talking about human resource, infrastructure, essential medicines, we are doing well in that area, we're not so bad. Financing, we have lobbied, and starting next financial year, we've been assured better financing. So, I want to assure this House that hosting the World Kidneys Day at Hoima is not a mistake. And I want to thank the organizers and the association for choosing Hoima to host this day, because it gives us an opportunity to share with the world what we have at Hoima, what changes, what progress we've made, but also areas where we need support. Dr. Njema has supported the team well, because it comes to knowledge and skills he has acquired, but we need to do capacity building for the other colleagues in the region. I want to thank you for God of my country.
Thank you very much for those remarks, and thank you for welcoming us to your city. We are privileged, yes, and Dr. Njema, thank you for making UKF shine. Yes, so earlier on I was introducing our next presenter, Dr. Abujo Karo. I would like you to come and make your presentation. Thank you. This is our pediatric nephrologist that we are so proud of. Actually, when I saw you, I remember that I have a consult for you.
Did you bring the child here with you? Okay, thank you so much for that introduction. Good morning, everyone. And I'm happy to be in Hoima City for the first time. We came at night, and I was asking my colleagues, hope we'll have some time to tour a bit. I know the program is tight, but please don't take me back before Nyende takes me around the old city. So I'm Dr. Abujo, one of the 16. It's still a lot of work for us in pediatrics. We are still 2 or 3, but we're trying our best. So I'm making So I'm going to talk about the organizers were specific. They wanted me to talk about acute kidney injury, severe malaria, and dialysis options for children. But I tweaked it a little bit, and I'm going to focus more on like management tips, the things that we always see with all the children that are referred to us. We all know that severe malaria is raging again. Maybe at some point we were winning, but malaria is a problem, really. And it's among the, I would say actually the commonest cause of AKI right now, at least from our world. So as we know, AKI or acute kidney injury in low and middle income countries, it mostly follows infectious causes and it affects young people. Whereas in the developed countries, you would see maybe old people who have had surgery or who are in ICU, but for us it's young people mostly, infectious causes, malaria, sepsis, pneumonia, diarrhea, and among children with severe malaria, about 30 to 50% can develop AKI. My slides are not showing well on the screen. I don't know. So the slides are showing half. Here I wanted to just remind us the definition of AKI. I'm sorry, the IT person is telling me that there are some people who sit outside, who are seated outside, who are supposed to make the slides, so I don't know who is that. But I'll just go on for now. So one of the challenges we have is the definition of AKI. This is KDIGO definition that tells us that your creatine should have increased by 1 or 1.5 times your baseline, or by more than 26.5 within 48 hours. But many times, all the time, we don't have a baseline creatine. So what we see is that people, and then our labs give normal range of creatine for adults. So what we see is that people miss the AKI. They look at creatinines of 100, 70 or 80, and it's a child, and we think it's normal. But for a child, it is already AKI. So we don't have the baseline, but we also encourage people to try and use the urine output. You just ask, if you have a very sick child on the ward, always ask the mother, is the child passing urine? Is it about the same number of times per day? Is it the same number of pampers that you're changing? Something like that. So you have an idea. If you're lucky and your patient had a creatinine measured maybe in the last 7 days or so, then you can detect that the creatinine has increased. So, and also creatinine, the lab results always take long to return. So don't forget to ask about urine output. It's something that is easy. And then, so for severe malaria, I've not gone into how common is malaria in sub-Saharan Africa. We all know that. But when you have severe malaria, there are different mechanisms by which you can get AKI. And one, it is multifactorial, we say it. Many times these children are very sick, they have high temperature, they are losing fluid. They are vomiting, they are losing fluid. They are not feeding well, they are not having enough fluid in them. Sometimes the mothers will give some herbs, adding more insult to the kidneys. Or they will give, it's very common, NSAIDs, child is very hot, they are sweating, they are not feeding, they are vomiting, and then the clinician adds on some IM, diclofenac or rectal to control the fever, and that also adds on more insult to the kidneys. Malaria, we know that when the malaria parasite gets onto the RBCs, they start hemolyzing, and you hemolyze both the RBCs that have the parasites and those that don't. So that hemoglobin that you release is also toxic to the kidneys. And then the RBCs also block the small vessels within the kidneys, so you kind of obstruct blood flow to the kidneys, and all that contributes to the kidney injury. So there are many mechanisms. The traditional way we used to teach that AKI is prerenal, intrinsic, postrenal. For malaria, it's like you have the whole spectrum. So what we have been doing is trying to train people on early recognition of AKI and prevention, and then proper management. So we have a small program that we are running, and what we are trying to do is we are encouraging people to screen people who are at risk of malaria. So if you look at your children's ward, for those who are working on the wards, any child that is admitted on the ward is at risk of acute kidney injury already by being admitted on the ward. So you just keep in mind, keep a high index of suspicion, ask about urine output, make sure they are well hydrated. Many times children are not well hydrated, and we are only giving the attachment or the antibiotics. And then we also want to prioritize prevention of AKI and then timely management. So we want to improve outcomes of children, because we notice, so we have the figures from this QI project, the mortality is high, late diagnosis, late referrals, and then we are trying to work towards reducing those and improving the outcomes of children. So that's a child who has a hemodialysis catheter at the right internal jugular vein. So who are at risk, it's good you have an ICU, but I know that it's very hard to get ICU bed for children, even in Lago. I don't know how it is in Hoima. And many times medicine gets advanced, and then we need those services, but you can't get them. So we also have children who need ICU. But as I've told you, the best is to say whoever is admitted on your ward is at risk of AKI. So then neonates, you have improved maternal health outcomes. I don't know how good you are with the neonatal outcomes. The low birth weight, the prematures, they are also at risk of AKI, asphyxia. Then people who are using nephrotoxic drugs, especially the NSAIDs in our environment. And then also children, because children who have underlying malignancies or already chronic kidney disease or sickle cell. We have a lot of patients with sickle cell also who get AKI from different mechanisms. So why are we saying that have a high index of suspicion and screen the high-risk groups? So part of what we are doing here is to improve awareness for kidney disease. And we want to say that also children get kidney injury, they get kidney failure, and people come in the ward in lab and ask you, but they do. So screen high-risk groups, and we need to prioritize kidney injury. So I will not talk much about this. We designed this screening tool, we put it in our emergency ward in Mulago to help people think about AKI. If a child has severe malaria, if they look dehydrated, if they say they have reduced urine output, if they have used any nephrotoxic drug, or if they are passing thick-colored urine, then you must suspect AKI and go ahead and look for it. So we are emphasizing urine output and measuring serum creatinine. So this slide, I always put it just to make people realize that the normal ranges for creatinine for children are lower. Don't interpret them according to what the lab has given you, because at least for Blago now, they are giving us the children ranges, but many times they give the adult ranges. So don't think it's normal. So assess fluid status, maybe I'll skip this one because of time. We want to make sure the child who is on your ward is well hydrated. Don't be treating a child who is dehydrated. Don't be treating a child who you don't know whether they're even producing urine or not. And by the time you realize the creatinine has gone up, and actually when you ask the mother, they will say, yeah, I didn't have, but once the mother didn't know. So you are the one to ask. You find the child who has taken 2 or 3 days without passing urine. Even they come to us and then you ask them, they last passed urine like 4 days ago. but someone has been treating them. So we need to ask about that. So fluid management, these are the main bullets. We need to manage fluid, and we don't have to put IV fluids in every child. Just make sure they are well hydrated. Encourage the mother to give more fluids. If you need an NG tube, put an NG tube. So you manage the electrolyte abnormalities, control blood pressure. I know it's very hard to get blood pressure equipment for children. I don't know what they have here. But we actually get blood pressure problems in children with AKI, and you need to manage that. Just allow me to take a few minutes here. What we realize, people always struggle. To determine which child should I encourage to give more fluid, which one should I restrict. If the child is sick on the ward, just make sure they are well hydrated. The way you assess them, the skin pucker, maybe they are producing tears when they cry, the pulses are good, you know. But if you notice that they look dehydrated, encourage more fluids. But then if you realize there's no urine or there's little urine, then you have to restrict fluids. But drawing the line between who should I give more fluid, you need to think through your patient. Because some patients need a bolus of fluid, and then when you hydrate them, the urine actually starts coming. But if there is no urine and they begin to swell, then you have to restrict the fluid. And you give incense bottles, you add on any little urine they are passing. Because we struggle with this actually. So people keep giving fluid because there is no urine, yet the person is now swollen. Then they begin to get respiratory distress, and then they are now looking for you for dialysis. So on the wards, just be on lookout. If they are swollen, the little urine, you need to restrict the fluid, and the kidneys recover with most of these acute conditions. So for hypertension, we prefer to use calcium channel blockers. Avoid ACIs. They have been talked about. ACIs and ARBs for CKD, but in acute kidney injury, many times you're also hypovolemic, so you don't want to use the ACIs or ARBs. If your BPs are low, you may need vasopressors. Nutrition will be talked about, but you need to encourage the feeding. Even though they are not able to feed orally, you can use an NG tube. Drug management, another thing people always forget. If you're having AKI, someone has little urine, creatinine is rising, look at your drugs again, look at the drugs you're giving. Some of them may be adding more, they may be nephrotoxic, and then you have to stop them or adjust the dose according to the level of kidney injury. And then of course the electrolytes. I always tell the students and the teams that the doctors we work with that every doctor must know how to manage hyperkalemia. So you must teach yourself. You cannot have hyperkalemia and then you're referring or calling somebody. You need to know how to manage because it's an emergency. And as you're managing your patient and monitoring, you need to realize or anticipate whether you're going to need kidney replacement therapy, and you refer the patient early. So this is really like what I've already been talking about, but we focus more on AKI in malaria. So we want to avoid toxic medication. Volume status, you assess and treat accordingly. If you need to give fluid to the child, give. If you need to restrict. And then avoid nephrotoxic. So I'll share this. I don't see the pediatricians of Hoima here, but I wanted to share with them this monitoring form. It has helped us a lot on the ward, because sometimes you talk, what do you monitor? We monitor the weight, monitor the urine output. But when you have a patient with you, if you don't do these things, you actually don't know where you're going with your patient. But when you don't make this monitoring, then it guides you when you're managing. Indications for dialysis are the same, and you have to know at what point do I now need to do the dialysis for this child. I'm not winning with this hyperkalemia, the urine is not coming, so you need to plan for dialysis. Or the child has anemia, they are convulsing, they are bleeding, then you need to prepare for dialysis early. And we use for dialysis options, we use both PD and hemodialysis, and as we have also described in that article. So here I was just sharing some of the things that we've done. We do improvised peritoneal dialysis. Last year we did this, and one of our senior doctors said he will take us to court for doing dialysis with the improvised fluids, but this has been well researched and you can do dialysis improvised. And I'd like to have a chat with the pediatricians of Hoima, if I meet them, that they can actually do this peritoneal dialysis here in Hoima for the small children with the help of a 3-way tap. And then, yeah, so the indications for dialysis are the same. The outcomes are always good. So we have these manual setups that you can actually use to do peritoneal dialysis in children. Then here we did just showing from our data the children that we've done hemodialysis. You can severe malaria is still the commonest cause of AKI, and the commonest indication for dialysis comes from severe malaria. Yeah. The referrals, patients come from all over the place, the outcomes are good. So prevention of AKI, just prevent malaria, prevent diarrheal illnesses, prevent infection, encourage mothers to immunize the children, you prevent pneumonia, meningitis, sepsis, proper water and sanitation, prevent asphyxia, prevent prematurity, all those things, if you do them, you prevent malaria. And then remember to follow up your children after the severe malaria episode. Some of them may develop CKD. Thank you very much.
Thank you so much, Dr. Carol. Members, may we give her a round of applause? And I hope the nurses who are in the house will add something about the fluid management. Let us take home that message and share it with our colleagues. And at this juncture, we have another presenter who is coming in to handle something we are calling Peritoneal Dialysis, Uganda's Experience. And that will be handled by Dr. Oriba Lamoya. So Dr. Oriba is a physician and head of Department of Internal Medicine at St. Mary's Hospital, Lacho, and he serves as an honorary clinical lecturer in the Department of Internal Medicine at Gulu University. Dr. Oriba pioneered peritoneal dialysis in northern Uganda, expanding life-saving renal care to underserved populations and advancing practical solutions for patients where access to specialized treatment is limited. Ladies and gentlemen, Dr. Oriba, you're most welcome.
Thank you very much. We started our journey right from Gulu at 4:30 in the night this morning, and it's my first time to be in Hoima. It's a very beautiful city, and I must also admit that it's very difficult to speak after your seniors have spoken. I'm very happy to see Dr. Chigundu Daniel. Chigundu supervised me for my MMed, and is the reason why I pursued nephrology or took special interest in nephrology, and of course Professor Kazi-Njema is also here. I'm very happy to be with you all here. Thank you very much. We are going to go through briefly on our stride in peritoneal dialysis, especially in 2023 when I completed my MMed. Few months after completion of my MMed, I was in St. Mary's Hospital Lacho running the ICU department and also internal medicine, and people were dying from acute kidney failure. And I think from our discussion with Dr. Chigundu, we started something small. I started researching on PD fluids, and we started really making it from first principles until we came to a very clear fluid which is already known. And at the moment, we shall also talk about Uganda's strides from 2023. What have we done to make sure that this goal is realized? Peritoneal dialysis requires periodic installation of dialysis into the peritoneal cavity, and this normally induces fluid across the semi-permeable membrane, which is your peritoneum. And it's a procedure which has been dated back until 1923. And Tenkov and his colleagues started practicing it in 1968. Though not so many people have adopted it, but currently in several countries we now have PD first policy, and I can assure you that even when you see Baxter has already closed of its hemodialysis units and is now concentrating on PD. And part of this, we have also started designing self-PD machines whereby if someone has chronic kidney failure, you can just put the ingredients, it mixes for you like a coffee machine, instills it inside your abdomen, and after some time it brings it out. So that's the stride which I'm very sure that one day it will be realized. But going to the challenges that we have, Uganda is among the Africa's fast growing continents, countries, with a population of about 48 million in 2023, yet resource poor, with 42% living on less than $2 per day. Hemodialysis is very costly, and I think you will see from one of the studies that we have written with Professor Kadesfur and Grace Kansime, out-of-pocket care is very expensive, so we need to look at innovative solutions which are easier for patients and for our continent, which is growing. Now, this demographic transition, coupled with few healthcare professionals trained in management of acute kidney injury, of course, limits capacity for early recognition, appropriate management, and timely referral of patients, leading to suboptimal care. It's important that we, as a country, need to invest in management of acute kidney injury, because in the long run, if these patients are not managed very well, they are the one going to transition to chronic kidney disease. So what is the issue? I think Dr. Caroline has already talked about AKI. I'll just put this. I mean, AKI is abrupt and usually reversible decline in glomerular filtration rate, and no particular form of renal replacement therapy for patients with AKI has been clearly shown to show benefit, whether it be hemodialysis or peritoneal dialysis. But it depends on the expertise of the person who is doing it, the availability of resources, then you can choose that. In northern Uganda, it is really resource poor. At the moment, we are a dual center, whereby at St. Mary's Hospital at Joe, we can do for you both PD, and we can also do for you hemodialysis. As I speak now, we are shipping one of the machines, which is really high-end for our ICU, to complement what we already have. And I'm very sure we should be able to do CRRT as well in the future. The types of renal replacement therapy, of course, where you see there on your left is peritoneal dialysis, and then on your right is hemodialysis. But before we dive onto what we have done on peritoneal dialysis, let us look at this beautiful pediatrics university. This patient had very high potassium of 8.9. And you can see this, the sine wave pattern and bizarre QRS complex, broad complex QRS and tall tented P waves, impinging sine wave pattern, and a pseudo right bundle branch block, which comes with severe complications of AKI, hyperkalemia. The second one you see here is a patient with a dual electrolyte abnormality. This patient had prolonged QT interval, which is showing you severe hypocalcemia, and that one tells you that For every patient, you must stabilize the cardiac myocyte by administration of calcium gluconate, and also had hyperkalemia, signified by the tall tented T waves. These are patients in the ICU that are treated successfully and they became well. We have done so far 121 peritoneal dialysis in our setting, and I must say that Professor will ask me why I have not brought this, but I have personal challenges that I've told him, family challenges that I've told him. My son was very sick and has put me back into track of pushing for some of the things. But Professor, these things will be published. I'll put the data before I leave for Gulu on your table. We should be able to have it so that we can bring this data and do very nice advocacy for our patients. So our outcome is very good. We have a 95% outcome for our patients with AKI. And I think this is very good. Ever since we started it, we have lost 6 patients that we think we are still trying to lose. After that, we have not lost any patient with acute kidney injury. There is significant decline in median creatinine after dialysis. You can see here you have 9.6 before dialysis. After dialysis, the creatinine range came back to 1.7. This is very good, and normally their hospital duration of stay is not very long. And we conclude that locally improvised peritoneal dialysis is still safe, feasible for managing acute kidney injury in resource settings. This very beautiful table that you see here was extracted from Global Perspective on Acute Kidney Injury in Uganda, and I think Professor is a lead author, and Dr. Kazi-Njema and myself. And we highlighted the commonest causes of AKI, which I think Dr. Awujo has also mentioned. Malaria still remains the leading cause, and then of course there's others. Complications of AKI that may require emergency kidney replacement therapy. This is very well known for us, and you have pulmonary edema, hyperkalemia, signs of uremia, especially pericarditis, or otherwise unexplained decline in mental status, severe metabolic acidosis, sometimes acute poisoning. And even in our paper, we put once a child comes to you, or someone comes to you with kidney failure and requires blood transfusion, you should know that most likely they are going to require renal replacement. So the management of AKI, she has put it very well. It is normally supportive. Treat the underlying cause, sepsis, dehydration, hypertension in adults, malaria, dehydration in children. I manage children a lot in our ICU, so just know that as an internal medicine physician, my work starts from 12 years. Internal medicine at Lacho Hospital starts from 12 years until Pediatrics, because of funding, the funders decided to start from 11 years and below. So we have a very good fund for children where they don't pay for anything at St. Mary's Hospital. Stockouts, general doctors handle initial cases and referral for kidney replacement therapy, limited access to specialized nephrology care. Dialysis services in Uganda, we have St. Mary's Hospital, not very many, you can see that really. Only those sectors are really. Let us try to make more advocacy to make this available. The cost of dialysis is very high, and so we must pioneer locally made fluids within the country. We cannot afford to import peritoneal fluids or even import fluids from another country to bring it here. Uganda is blessed with abundance of water supply, and I'm very sure the knowledge is also there to make sure that this is made. The benefits of the ISN Young Saving Lives program, I'm actually part of the Saving Young Life program, ISN, and we started with peritoneal dialysis, peritoneal dialysis using NG tubes. You can see the first one is an NG tube, which we were trying with multiple complications, of course, but we were very successful with it. Then, of course, we introduced curved hemodialysis catheter, which is percutaneously placed after preparation of the bowel in these patients, and it has excellent outcome with no leakages. And this, I thank my mentors, Professor Rashad Dawish from Egypt, Brett Cooley in South Africa, Elena Boyes in the UK, and Nicola from South Africa. And then, of course, my home mentor, Professor Kaleso Robert. Advocacy for peritoneal dialysis in Uganda. We made headlines in 2025. Kidney care in Uganda makes breakthrough. I mean, we wanted to just show that, this is possible, and also to invite potential investors to come to Uganda to bring on this work too. And as part of this, we had a training whereby the Jinja Regional is going to be a pioneer of peritoneal dialysis in the country. We went with the Dr. Olaro Charles, who is our Director General of Health, and Dr. Yari, the Executive Director of Jinja, and several doctors already and nurses have been trained in PD. And I've also been nominated to be the ISPD Africa representative. I hope that will come to pass, so that probably we bring more investments and training opportunities for our healthcare workers in Uganda. So what have we done so far? Ministry of Health has partnered with the Impact Africa, and this training took place in Turkey, Ankara. Yes, this is my last slide. I think it took place in Turkey, Ankara, in Koro Hospital, and they are really advanced, and we train nurses and doctors on PD, and we also partnered with Pfizer, PISA, Mexico, who will be our peritoneal dialysis provider in this country. For the meantime, as we pursue locally made fluids within the country, because that's already in the pipeline, and I think it is very possible. Last but not least, we need to have adequate prevention and training, strengthen AKI prevention, early diagnosis, CME, CPD for health workers, especially at lower facilities, university and regional referral hospitals, collaborations, and then of course infrastructure, expand dialysis and ICU services with regional referrals equipped and staffed for AKI care. And I still talk on behalf of Gulu, Dr. Chigundo. The dialysis machine which was in Lira is supposed to be in Gulu, sir, because I remember we talked about it and you were preparing me to run it. Please make sure that you send dialysis machines in Gulu Regional Referral. Financial support, government and partners should subsidize dialysis to improve access for vulnerable groups. And we thank you so much for listening, and may God bless you all.
Thank you very much, Dr. Hoima. Dr. Hoima has always been amazing. He ventured in an area where let me speak for myself, where I personally thought I would also become a PD champion. But I have also done PD in one way or another, and I keep telling this story that I dialyzed a 4-year-old child, Ojo, just so you know. And I was really rewarded. I ate chicken, I ate chicken, I ate chicken, I ate chicken. Every time this child would come, the mom would come with a chicken and say, Doctor, thank you so much for saving my child's life. But at that time, Dr. Hoima, the concoction we're using was very cumbersome to make. So recently we had a grown-up with AKI. We put a hemo catheter, and then it didn't work, and then there was no money to get another one, so we had to call, and he gave me a very simple recipe, very simple. So we can all do it. Thank you very much, Dr. Hoima, for being very inspirational. Ladies and gentlemen, I hope you're still awake. This is the last presentation of this first session. Allow me to introduce the next presenter. I am not seeing him. Dr. Ernest Sewanyana is an intern or a junior house officer at Mbara Regional Referral Hospital. He just recently completed, actually, but he's already shining. He was at MAST. He's a nephrology wannabe, nephrology hopeful, and he's, I must proudly say, he's my mentee. He's already a member of the International Society of Nephrology. Ladies and gentlemen, please be informed that joining is free for people from LMICs. He's already taken short courses, ISM related. He's done basic statistics, in successful clinical research. He has already attended a scientific writing program. All these are ISM supported. So this morning he's going to be presenting results from work that was done on AKI among critically ill patients at Mara Regional Referral Hospital. Dr. Sewanyana, over to you.
A very good morning, everyone. Sorry, there was a technical problem that's being sorted. Distinguished guests from central government, local government, the founding president of the Uganda Kidney Foundation, current executive members of the UKF executive, my seniors and colleagues, distinguished guests, good morning. Dr. Riba, the great Dr. Riba Dan has just mentioned how difficult it is to speak after your elders. So you can all imagine what I'm going through. Ladies and gentlemen, my name is Ernest Sewanyana. I am a junior house officer at Mara Regional Referral Hospital, a member of the embattled group that you all call medical interns. I'm delighted this morning to present to you one of my very first research contributions and outputs, work that we did with Dr. Rose, who is more of a mother to me now than a mentor. And this work was done at Mara Regional Referral Hospital between February and May 2025. Before I start, I have two disclosures to make. These slides were adapted and improved from a presentation made by the corresponding author, the first author, at the MAST Annual Research Dissemination Conference in 2025. And this very work has also been selected for a poster presentation at the World Congress of Nephrology 2026. And the same work is what I presented at the ISN Scientific Writing course. Okay, so let's get started. For this study, we were looking at the incidence and predictors of acute kidney injury in critically ill patients admitted at our hospital at both surgical and medical emergency wards and our ICU. We defined AKI as by the KDIGO definition, serum creatinine increase of 0.3 or more within 48 hours, and we define critically ill patients as patients who had a national early warning score of 5 or more. We particularly use the NEWS 2 criteria, which are included for all our reference, assessing our patients by respiratory rate, SpO2, oxygen source, systolic blood pressure, pulse rate, consciousness levels, and temperature. And like I said, a NEWS score of 5 or more was considered as a marker for critical illness in this population. We all know that acute kidney injury affects millions of people. By the time this work was published, the most recent data was showing at least 13 million people, with close to 2 million deaths each year being attributed to acute kidney injury. And critically ill patients are more likely to get AKI because of the situations they find themselves in: nephrotoxic drugs, hemodynamic instability, inflammatory causes, and many other risk factors. However, we didn't have any data from our setting to describe the incidence of this big problem in critically ill patients who are admitted in the emergency wards. We know that AKI, being a reversible cause of death, is a major global health problem, and we looked forward to determining the incidence, the predictors of AKI, as well as describing how patients with AKI are managed and evaluating treatment outcomes. We included 161 patients in this study from a total of 420 patients admitted, and the flow chart is right there. On admission, patients were assessed by their vitals and scored using the NEWS 2 criteria, and whoever scored 5 or more was considered critically ill and subsequently recruited after informed consent. Data was collected as shown there, and follow-up serum creatinines at 48 hours after admission were done. This was also part of the study workflow, and we went on to analyze this data and determine independent predictors of AKI by logistic regression. The burden of AKI is very high, and as you can see, we found an incidence rate of 70 per 1,000 person days, with an incidence of 62.1%, meaning that out of every 3 people that were admitted in the emergency ward or ICU, at least 2 would get AKI in hospital. The median age of our population was about 48. This shows that the population was quite young, and these are people that would rather be expected to have normal kidney function. Most people were male, and most of the people who had AKI had been previously admitted in the last 3 months. Most people were admitted in the medical emergency, that's 52.8%, but people in the surgical ward and surgical emergency had much higher risk of developing AKI. Creatinine at admission was not so different between the 2 groups, but as you can see, the people who developed AKI had slightly higher creatinines at admission, as by a median of 1. The white cell count was also a very important predictor, above 12 having a higher risk of developing AKI. And indeed, the AKI group had very high baseline white cell counts compared to the non-AKI group. That's just a summary of the predictors of AKI that came out significant from the analysis of this work. Admission in the surgical ward was particularly associated with higher odds of developing AKI. Previous hospitalization was also associated with higher odds of developing AKI in hospital. Creatinine at admission, high people with higher creatinines higher than 1.2 had higher risk of worsening of kidney function, and people with baseline white cell counts higher than 12 also had higher odds of developing AKI. As you would expect, unfortunately, hemodialysis being an out-of-pocket procedure, only 2% of people in this study underwent dialysis. Albeit finding 8% of the participants in stage 3 of AKI, 8% in stage 2, and the rest in stage 1. All of them, or most of them, were managed conservatively. And as high as 25%, meaning 1 in 4, succumbed to AKI during admission. People also had more odds of dying in hospital if they developed AKI, as high as 2.2 higher odds of dying in hospital from all-cause mortality. The median time of hospitalization for these people was 6 days, and there was no big difference between those who developed AKI and those who didn't. So this was a cohort study, but at one setting, one study site, that was by Regional Referral Hospital. So there's a question of generalizability to every other setting. And having measured serum creatinine at 2 points during the time of follow-up means that we may have missed even more cases of AKI in this population. So despite having presented or found an incidence rate of 70 per 1,000 person days, if we had taken into consideration other parameters like urine output, maybe the findings would have been more surprising. So, what I have presented in brief is that there was a very high incidence of AKI in critically ill patients, up to 62.1%, or in brief, 1 in 3. People who had been hospitalized in the past 3 months, people who had higher white cell counts pointing to infection, and people who were admitted in the surgical ward, as well as those who had higher baseline serum creatinines, had higher odds of developing AKI in this cohort. And we have noted that only 2% underwent hemodialysis in this cohort. So what does this mean for you and I? And what does this mean for the healthcare system and nephrology providers, or care providers at all sites, including surgical and medical wards? Critically ill patients should be prioritized, and risk factors for AKI should be identified and monitored closely. And maybe the system should take into consideration interventions to make hemodialysis, access to hemodialysis more equitable, affordable and accessible. We thank the UKF and the Ministry of Health and all your efforts in reducing the distances traveled and the costs incurred. We hope that this can go on further and further to make dialysis more affordable and acceptable and accessible. I would like to acknowledge the following and thank you for your support to this work, and look forward to advancing care for people who are critically ill and reducing risks for acute kidney injury. Thank you.
Thank you so much, Dr. Ernest, for that wonderful presentation. Ladies and gentlemen, we're going to have the last presenter, and then after that we go to Q&A. So prepare your questions, as the presenters will also be ready to answer them. Lastly, we are calling in Dr. Francis Senabulia, who is going to talk to us about anemia and CKD and new opportunities. Dr. Francis is a nephrologist and works at Makerere University and also Mulago National Referral Hospital as a nephrologist. You're welcome.
Morning, everyone. As I've already been introduced, I'm going to be so morning, everyone. I'm going to be taking you through some updates regarding anemia and CKD. And a disclaimer, I'm just basically, I again summarize the KDIGO 2026 updates. Sorry. So I went ahead to basically make a summary regarding the administrative summary for KDIGO guidelines for anemia management. This is going to be the outline of the presentation. Definition for anemia, this one we all know. So according to WHO, for men, you have an HB of under 13 grams per deciliter, and then for females, it's under 12. For pediatrics, there are those 8 specific categories which they have to go ahead and have offset. Regarding prevalence, the most important take-home message is that more than half of patients with a CKD, stage 4, stage 5, more than half of them obviously are going to be anemic, and the severity of anemia is going to be high compared to the other stages of CKD. And the main complications or outcomes when the patients are anemic, they are quite broad. Higher mortality, the cardiovascular complications, LVH, coronary disease, lower quality of life, till down to higher medical costs when you're managing these patients. That is fine, people, HIF inhibitors, plus maybe transfusions, and right now that we are transplanting patients in Mulago, you'll find that for you to get units of leukodepleted RBCs, they are quite expensive. Etiology quite broad, but like we all know, we have EPO deficiency and deficiency, which also comes as a result of blood loss, especially in HD patients compared to PD. Then uncontrolled hyperparathyroidism, marrow suppression due to various factors, nutritional deficiencies, still to be some people who develop antibodies towards the EPO receptors who could be EPO hyperresponsive. So iron deficiency was quite stressed because it's the main cause of anemia in CKD patients, and the etiology is quite broad. You realize that HD patients are more prone to be anemic compared to PD because of frequent vein punctures. They are receiving heparin, so they are at risk of bleeding, blood lost in the dialysis and dialysis tubes. Then you have the nutritional deficiencies still because maybe people are having poor appetite. Then medications that can interfere with iron absorption, especially the PPIs. Then people who have a chronic inflammation with very high levels of hepcidin, which is going to block the ferroportin transporters at the macrophages and the enterocytes, they can end up iron deficient in the long run. And then obviously if you utilize erythropoietin stimulating agents, more so when the patients are not iron, people are going to end up iron deficient. This is a new terminology, which before we used to talk about absolute iron deficiency and functional. So functional is where you have patients who are having a very high ferritin, but the transferrin saturation is what? Low. More so in patients who have inflammation, which is ongoing, especially our dialysis patients who have catheters, plus other forms of inflammation. Then the absolute iron deficiency where both the ferritin and transferrin are low. So when you're managing your patients, get to know where your patient lies, because there are going to be a little bit some differences when you're trying to manage these patients, if you have access to performing those tests. And this still talks about the systemic movement of iron in different iron-related states. So if, for example, you have patients who are having a systemic iron deficiency, you're going to have hepcidin, which is quite low. And these patients are going to have their ferroportin transporters open, both at the macrophages and then also on the enterocytes. So you're going to have free saturation of iron. However, the deficiency is going to be just overall total body depletion of iron compared to your iron-restricted erythropoiesis, where you have hepcidin because of chronic inflammation being produced by the liver, and then it will travel to your enterocytes, block the ferroportin transporters on the basolateral membrane, and then inhibits iron release, and then to same thing to the macrophages, and then you end up with anemia. Approach to anemia management, some few changes compared to the 2012 guidelines. When you get these patients and they have CKD and you're trying to screen them for anemia, the basic tests are doing the CBC, reticulocyte count, ferritin transfer. They've moved away from you going ahead to do vitamin B12 levels, folate levels from the outset. So you first do that. Then if you confirm that the patients are severely iron deficient, that is a ferritin level of under 45. So, and the HB is quite low. For those patients, you're going to try to look for the common causes of blood loss. For example, if you think the patients are having hematuria, if you think it's a woman who is actively in their men, like still actively menstruating, that is if the CKD stage is not really that extreme end, because like we know in CKD, most patients are going to lose their menses. And then if you think someone is having occult GIT blood loss, so you're going to go ahead and either you can evaluate them or you refer to the respective specialists in those fields. And the current cutoffs in the dialysis populations, we are using 500 and then the transferrin saturation under 30%. Previously, we are using 200 and then 20%, so they have moved a little bit higher because we know dialysis patients often are at risk of anemia, like I highlighted. Then for the non-dialysis patients, the cutoffs are a little bit lower because they are at a lesser risk. Then if you've done the workup for your patients and they are undepleted, the guys are still anemic, HB is quite low, you're going to go ahead and do other expanded tests, like testing for vitamin B12 levels, folic acid levels, regardless of your MCV, MCH. Then you can obviously get your CRP plus any other suspicion, especially when you're in a resource-limited setting. You're going to evaluate your patient through history taking this examination, and then you will have to decide which direction to take, which investigations you're going to prioritize upon, other than bombarding the patient with all these tests that have been highlighted by Kazi-Njema. And then in your management, you're just going to obviously identify your cause and then you treat the cause. That is basically what this flow diagram was trying to highlight, and I'll go straight to the treatment. So treatment, obviously identify, treat the cause after your history, physical exam, investigations. And then one of the causes in new management of anemia and CKD, there is iron supplementation. Currently we have these new agents, the HIF, proline hydroxylase inhibitors, then the erythropoietin stimulating agents, and then lastly, transfusions. So quickly through them, benefits of iron supplementations, these ones, all of us know, minimizing transfusions, obviously will increase your HP, then also improving quality of life and minimizing hospitalizations. And then Kazi-Njema goes ahead to talk about the various indications for you to supplement patients with iron. Obviously, the CKD dialysis population and dialysis populations, like the cutoffs which I highlighted. Then if you have refractory anemia, and the patients have low transferrin saturation, and then also low ferritin, with high ESA requirements. So sometimes you might be in a dialysis unit, you're only raising your EPO doses from month by month or week by week. but yet your patients are inefficient. And if you go in our dialysis units and then probably you look around, how many patients are able to get a transfer in saturation done, especially public? How many patients are able to get ferritin being done? It's quite a very small number of patients who are able to access those tests. So I think we are trying to highlight these things so that for you, instead of you just hiking the doses of ESA agents, you better go test for these proteins and then you intervene accordingly. Then obviously patients who have heart failure with anemia, there are various trials for you for those of you who are interested in clinical trials like the FAIR trial, Ironman trials, Confirm trials. When you give iron supplementation to some of these heart failure patients, you improve quality of life, cognition, and other things among them. Then for initiating or withholding iron supplementations, there isn't any cutoff value which is accepted. So you, the clinician, you have to individualize your patients as you're managing them. However, they go ahead to tell you that in your CKD patients on kidney failure on hemodialysis, you can use that cutoff. Like I said earlier, dialysis patients are at risk of and very high risk of iron deficiency anemia because of the few factors which I highlighted. Then initiating in the non-dialysis population, the cutoffs are quite lower, and then when to stop. So for all your patients, when you're supplementing them with iron, if your ferritin goes beyond 700, you can try to cut down on your supplementation. However, still these figures are not cast on stone. There are those few patients who, for example, probably having what we used to call the currently, which they are calling, so your patients who are having very high ferritin but low transferrin saturation, you can go ahead to continuously supplement them with iron if you're suspecting that there is active inflammation which is ongoing. Though still, if the patients are having a systemic infection, you can decide to stop. So like I'm saying, those values, they are not always at the moment you find the patients are having ferritins over 700, you must always stop. There are those few exceptions where you can continue giving. There is this famous trial. In our dialysis unit, you can always look through which kind of strategy you're using. Are you using the proactive? Are you using the reactive? Reactive is where you just wait for patients' ferritin to drop under 200 or the transferrin saturation to go under 20%. So when we are doing this trial, we are looking at if you use the proactive versus the reactive, which is more superior. It came out that the proactive, whereby you try to give these patients monthly iron, a total dose of about 400 milligrams. These patients were having less primary outcomes, which mainly included things like strokes, heart failure, non-fatal myocardial infarctions, compared to those patients who they would have to wait and the ferritin levels drop under 200 and then they give iron supplementation. And then still, if you look at the red blood transfusion which are being done, it was still higher in the people where you had to first wait for the ferritin levels to drop. So for those of you who enjoy reading papers, clinical trial systematic reviews, you can go ahead and look up for that paper in the New England Journal of Medicine. This one, the members can go ahead and read about routes of administration. Obviously, oral, IV, and importantly is that there isn't any superiority in terms of, there isn't any hard evidence in terms of you giving IV versus oral. It's going to be guided by the severity of anemia, patient preferences, cost, availability, for you to choose whether it's IV or oral. And then still the different formulations of IV. There isn't any superiority in terms of what you're going to be using. And then as I rush through these, people can go and read about the advantages of oral versus IV. Monitoring, this is very clear. Annually, for those ones with CKD stage 3, if you look in our units, monitoring of anemia is people only do a CBC. But at least we could be going ahead to do these other tests so that we manage our patients better. For those who use ferrous carboxymaltose, always monitor phosphate levels in your patients, because they can lose phosphates and then you end up with disastrous outcomes. And like I said, no superiority in terms of giving either oral or IV. And we should be vigilant about the different toxicities, and then when you're giving the iron supplementations, and then the HIF inhibitors. For these ones, they are new agents. They try to augment the kidneys to produce EPO, and they are currently available in Uganda. However, Kediago still prefers the erythropoietin stimulating agents because of the long-term experience with them, safety in the real-life situations. For the HIF inhibitors, for these medications, evidence is only in clinical trials. There are only special circumstances where you can probably use them. ESA hyperresponsiveness, intolerance to ESA agents, and then where there is impractical use. However, still they advise for you to prefer using those agents. And then be aware still of the risks of major adverse cardiovascular events like thrombosis for people who have polycystic kidney disease, proliferative DNA nephropathy, pulmonary hypertension, and pregnancy. So this one, most people will know the erythropoietin agents. And then lastly, I'll just mainly talk about blood transfusions. Currently, with the ongoing transplantations, you should highly select your patients who are going to be transfused. And you realize that as you give blood transfusions, more so if they are not equally depleted, you're going to sensitize your patients. So highly select your patients whom you'll be transfusing, so that you minimize this patient. You try to increase their chances of being transplantable, because if they start developing ESAs, start developing very high PRAs, you're going to deny them a chance of being transplanted. Thank you at this point in time.
Thank you very much, Dr. Senamulia. Another round of applause for him. Yes, I want to thank all the presenters that we have had for this first session. I know we didn't start on time, so we are running late. However, allow me to invite all the, remember we promised that we'll have a Q&A session, a brief one. So let me invite all the presenters to take the seats at the front. You know yourselves, my president, my son, and the rest. And my sister. Yeah, so let me start taking questions. I'm sure some people would like to ask. We'll try to keep it brief so that we quickly have our tea.
Yeah, thank you so much, our dear presenters, for the very informative presentations. I'm Dr. Mlezi Solomon, and I'm a senior house officer, internal medicine department, Kazi-Njema University. Yeah, I have about three. The first one we saw in diabetic kidney disease. We saw some drugs like SGLT2 having a nephroprotective effect, and we were encouraged that they should be started on patients who have EGFR of at least 20. Yeah, maybe what I wanted to know, is this an absolute contraindication or it's relative? And if it's relative, under which circumstances may we start those patients on the SGLT2 even with EGFR less than 20? That's one. Secondly, I think the first question goes to Dr. Oku, kidney. The second one, when we are looking at conservative management of kidney diseases, we looked at certain things like salt limitation, and what literature says, especially when it comes to salt limitation, it normally puts the amount of salt to take in 24 hours in terms of looking at the practicality of that in our setting, like what you're going to tell the patient, it may be a little bit challenging to tell the patient that in 24 hours you should take less than these grams. Are there some practical measures or ways that we can use to quantify that so that it can help us really give the patients the information that we think they are going to make use of? Like maybe in terms of tablespoons or teaspoons, how much sodium they are supposed to take in 24 hours, other than looking at the grams or milligrams in 24 hours. The last one is on, we saw AKI, especially the AKI in children, and also a very interesting research that was presented here, looking at the incidence of AKI in critically ill patients. The study that was done in Bara. Thank you. When it comes to diagnosis of AKI, mainly we were using Keynote. And first of all, we were looking at using serum creatinine and comparing the baseline serum creatinine and the one we obtained at 48 hours, and to see whether there is an increment exceeding 0.3 milligrams per deciliter. But we know most of the patients, it's hard to, they come when they don't have the baseline creatinine. And I'm looking at the patient who comes with serum creatinine that's already deranged. And of course, you don't wait for 48 hours to take the measurements and you intervene. You're going to intervene immediately. And then I believe with the interventions, if you did another check of serum creatinine at 48 hours, you may have a drop from the baseline, from the interventions. And now looking at our definition of AKI, comparing the baseline creatinine, assuming when the patient was admitted, you took the serum creatinine at that level and you took it as baseline, and then after 48 hours, because of your interventions, instead of getting an increment, there is a drop. So is that patient going to be seen as someone with AKI or not? And I know in our setting, it's hard to get real-time biomarkers such as NGAL, kidney injury molecule 1 and interleukin 18 that will really give us some real-time information as far as acute kidney injury is concerned. And also, lastly, still related to that, under which circumstances can we estimate the serum baseline creatinine? Thank you so much.
Thank you, Dr. Mlizi, for your questions. Ladies and gentlemen, time is not on our side. I request that we be mindful and ask with precision. Thank you.
Thank you so much. Dr. Kira is my name. I'm a physician practicing in Peritoneal Hospital. My concern goes to, I think, Dr. Okavu. The threshold for sending patients for a biopsy, especially patients with CKD, with diabetes. My other concern is a bit general though, that many times we refer patients to hospitals and we fail to get the right help, especially when we come to nephrology patients. We would like to have an opinion of a nephrologist, for instance, especially with advanced CKD. Many times when patients come back in our setting, they may have interacted with either a fellow colleague at your level or even a colleague below your level. I don't know how UKF is going to improve this, that maybe we refer to nephrologists rather than referring to hospitals. Many times, especially in the public setting, they will end up either seeing a colleague at your level or even a colleague below your level, and we are getting challenges. Thank you so much, and I want to wish you happy
World Kidney Day.
Thank you.
Thank you so much. My name is Achai Bikne. I work in Hoima Regional Hospital as the SPMO. Currently, you can call me PNO. I'm not answering a question, but it is a concern about the ICU beds or dialysis beds. I become actually stuck of which type of beds we should do, but my thinking is straight away is ICU beds for managing these patients. And when the patient has come out of critical condition, we need HDU or an ordinary bed. So my concern to Dr. Carol is, Dr. Caroline, what has the country done to ensure that actually these are made abundant in health facilities? Because when we were starting our dialysis here in Hoima Regional Hospital, it was really challenging. Chirudu came with everything to start us off, and when we reached the beds, they said, oh, go to SPMO's office. So we became stuck, and you know, our country facilities are limited. So we had to start with the available beds that we have. So my concern is let this type of equipment be made available to all the satellite or all the health facilities in the country. Thank you so much.
Any more questions? So we are taking only up to 6 questions. Then we
Good morning. Thank you, our panelists. Thank you for your presentations. I'm Dr. Judith Amuthaire. I'm a physician, a nephrology enthusiast, and research scientist. So my question goes to Langoy, Dr. Hoima. I mean, it's good strides you're making in peritoneal dialysis, but I know one of our biggest concerns with peritoneal dialysis is actually the peritonitis or the peritoneal infections. And of course, out of the acute care setting, the real benefit of peritoneal dialysis, particularly for us who are looking at costs of dialysis, will be getting it to the patients with chronic kidney disease and to ambulatory care, and I mean home-based peritoneal dialysis. So as you set up, as you go into the plans of rolling out peritoneal dialysis and expanding it in this country, how do you envision us overcoming such a big hurdle, especially given the kind of environment our people come from? And then for Dr. Sinauri, more of a guidance regarding anemia. So we always talk about delaying transfusion, especially if we have prospects of transplant. For how long can we delay the transfusion? Or is there any particular guidance on what you can do if you find this patient needs to have the transfusion, but maybe they are not far from their transplant? And then is there a role of combining HIF inhibitors and erythropoietin?
Thank you so much. I've been talking without introducing myself. I'm called Dr. Bira Adrian. I work at Hoima Regional Referral Hospital, internal medicine, dialysis unit. I've done 1 level of dialysis. My question, thank you our presenters first of all. My question goes to Dr. Carol Judith, who presented about AKI in children. Doctor, I want to ask if there are any studies so far to compare hemodialysis with peritoneal dialysis, especially in children. Here in Hoima Regional Referral, for now we are doing hemodialysis, and the youngest client we have so far who is still undergoing dialysis with AKI due to severe malaria is 14 years. I've not seen dialysis being done in a child below 10. I want to hear from your experiences of dialysis in children below 5 because they are the most victims of severe malaria. And then you talked about improvised peritoneal dialysis. Of course, when we talk about improvised, it's not the ideal, but it is feasible to save. I hope I will not be punished by my bosses. Though this is oil city, Hoima region referral is in the oil city, we still have a lot of resource limited issues. So we also improvise a lot. But I wanted to know how easy to improvise with this peritoneal dialysis, where we can pick up from. Thank you. The last question for that session.
Thank you, Dr. Rose. I have 2 questions. One is not a question, but just I want to palpate the thought process of Dr. Oliver as regards peritoneal dialysis. You talked about peritoneal dialysis mainly in the concept of AKI. I wanted to know if in your set you've done any peritoneal dialysis in chronic kidney disease patients, and if so, have you explored the possibility of home peritoneal dialysis? Now that we realize that we are serving patients who come from very distant places, have you tried that for patients in your setting? Then my second question is to Dr. Chubundu. Thank you for the presentation on conservative kidney management. I wanted to understand if when profiling these patients for chronic kidney disease, is it age to consider? Is age an absolute, or is age one of the things that you would consider to deny someone dialysis and consider them for conservative management? Someone could be 90. Does that put them on the conservative arm of things? Is it comorbidities? Is it affordability? Probably if you could shed more light on that, because we've had patients who come in at extremes of age, and then the discussions are a bit guided as regards whether to start them or not. Thank you.
Thank you. So let me allow the presenters to take the questions in no particular order, but probably from the beginning of the table.
Thank you very much. I will not waste a lot of time. Thank you, Dr. Judith, for the question of peritonitis. It is well known that peritoneal dialysis is not done very well. Patients will get peritonitis. In fact, when we started using improvised catheters with the NG tubes, we got some patients with peritonitis, but they recovered. In the long term, what government is doing is that we are going to have catheters, standard peritoneal catheters, both the swan neck and then the tank of catheters available in the country. By now, it should have been here, actually, as I speak, and we should have had patients 0-1 peritoneal dialysis with all the fluids, but I think because of technical delays, this has not started, but I'm very sure it's going to start. Sepsis is a major problem, both hemodialysis and peritoneal dialysis. So we have to take extra precautions to make sure that patients don't get sepsis. In our fluid management, when we started the PD using improvised fluids, we make it under septic techniques, and the exchanges are done under septic techniques. The only challenge is that, the only good thing is that this is normally short-term dialysis, and so the patients don't get sepsis. But yes, in the long run, if you use improvised fluids, risk of sepsis becomes very high and peritonitis. And so that's why we are pushing for, the country should have a manufacturing plan for fluids in the country. We should have a catheter which is really, really available and placed in the patient. And we teach patients, and then of course, we start first of all with in-hospital dialysis, then afterwards, we teach attendants and patients on performing exchanges, because PD is actually a home-based solution. And normally you prepare it in the ratio of 1.25, which is already prepared sometimes 2.5 or 2.7, and then 3.5% solutions. And they are not very different. Going back on chronic kidney disease care, it's something that we have not explored, but just recently before coming here, I had my nerves pulled to accept a patient of chronic kidney disease care after failing on hemodialysis, and it was very difficult. But I'm very sure that with the already made fluids, where you are very sure of the infection control and very nice catheters which are placed without any leakages, patients who are on peritoneal dialysis have better quality of life than those on hemodialysis. So let us not shut it down. This is going to be a very big thing, and all of you should open your mind to it. Thank you very much.
Great answers, Dr. I look forward to the day that more patients are being pediatric at home. I know one person, a doctor from northern Uganda, did it, but that was many years ago. There are two questions for me. One is about salt restriction and practical advice. The practical advice, usually, that we've had for many years is once foods at the table, don't add salt to it. That's one way. Another way, it says make sure there's some salt, but less